Hello, everybody. I get the awesome opportunity to introduce our amazing staff members. We in this group of incredible people. We have PT, OT, speech, and therapeutic rec. So this topic is the 5 and 50. So good luck with these guys being able to talk about their topic in 10 minutes because that's what they've been asked to do. So they might be talking really, really fast. But of the people that we have that are going to be presenting, we've got Ryan Bloomer. He's one of our physical therapists in the outpatient arena. He has been with us since 2018. Since he started, I have been trying really hard to get him to not be with us, but he keeps showing up every day. So thank you, Ryan. Jeremy Davis is our therapeutic recreation specialist who works in our Glenwood campus, and we're super, super lucky to have him and the amazing things that he does also with the dog Boo. Megan Erke is one of our speech language pathologists who happens to work in the inpatient department, and she actually has been with us for the last 12 years and does a phenomenal job on the inpatient side, treating everybody. And then we have Sue Sandel, who is an occupational therapist who's been in the outpatient clinic since a long time, 9 years, 9 years, something like that, sort of specializing in Parkinson's disease and also vision and all things OT related. And lastly, we have, and definitely not lastly, but lastly, we have Chandler Yoakley, who is also one of our speech language pathologists in the outpatient clinic, specializing in big and, or not big, your speech, loud, and all things speechy. So please welcome our 5 and 50, and good luck to them for the 10-minute spiel.
Good morning. So first and foremost, I want to apologize for my very lovely voice I have. Thank Mother Nature and Iowa for it. Okay, so I need to figure this out. There we go. Maybe. There we go. Okay, so I have the pleasure of getting certification in what's called Part A, or better known as Parkinson's Art of Expression. And so today, understanding the importance of Part A in people with Parkinson's disease, but also how to incorporate it throughout other treatments. So the background is Stephanie Goodman is a CODA by trade, but she is another staff member at the Parkinson's Exercise and Wellness Center in Kansas City. But she also has a love for drama and theater. And so she was able to do some research and figure out a way to encompass both of them to do kind of a fun wellness program. And so she developed this based off a grant through the Parkinson's Foundation. So some areas of focus that this Part A focuses is balance, intentional movement, spatial awareness, cognition, voice, emotions, expression, communication, and the list continues. But you might wonder why doing it with theater. So many people with Parkinson's have difficulty with intentional movement. They have difficulty with that low voice and that flat effect. They can also have difficulties with their cognition. And so with theater, performers have to be very intentional about their movements. They have to know where they're going on stage. They need to know what their next movement is going to be. They need to remember what they're going to say. They need to also have that divided attention and not run into anybody else on stage or overlap what someone else might be saying. And then they really need to have that good breath support to talk to a whole audience, to portray what they want to get out. And the emotional aspect, I think, is the kind of big one. It needs to have emotion to invite and to understand what the actor's world is and to understand the actual play or the drama that you're watching. And this is one that's big and hard for people with Parkinson's to do because of that thought effect. And so incorporating all of these things into a programming is it made it really fun. And then it also looks at promoting neuroplasticity. So the spatial awareness, the react, the act and react aspect, just building those new connections within the brain so that they can move a little bit easier or be more intentional. Yep, right there. So I'll just continue. But some ideas from the treatment is based on mental imagery, visualization, mindfulness, getting that exercise, dual tasking, social interactions, and building confidence and camaraderie. Okay, so all of these treatments can be completed and modified for each level of Parkinson's. So if you're not familiar with Parkinson's disease, there's several stages of the Hoehn-Yahr. So it can start from being unilateral to bilateral to being in a wheelchair. So currently we're using Part A in cognitive fitness, which I hold weekly for individuals with Parkinson's disease. This is via Zoom. We can get it. I would shout, but I don't think.
Check, check, 1, 2.
Thank you. Can you hear me better? Okay. Eventually, we would like to implement it as a wellness program with our Parkinson's population. So that is in the works. Not many people know about what Part A is, so it kind of makes them a little bit leery, but that would be something that we'll continue to incorporate. But currently, I also use some of the ideas and techniques with my other neurotreatments. So one idea is embellished introductions. So you may be in a medium-sized room and you have a point spot for this person in front of an audience. And so you have them walk on stage to their point, being intentional with their movements. Maybe if they have freezing, you will ask them to count how many steps they think that they can get to that one spot that they need to. And then using their voice and taking that deep breath, projecting their voice, introducing themselves, and maybe sharing another question, like, what is your biggest pet peeve? Or maybe just, where are you from? And focusing on that fluid movement, the eye contact, standing tall, good posture. This is something that I have even done, the intentional movement to a spot with someone recently with not Parkinson's, but just having difficulty with movement. I often have people have trouble freezing at the threshold of my office. And so I will have the chair at the table. And I often will say, okay, if you're going to be freezing, I want you to stop. I want you to look at the chair. And I want you to tell me how many steps you think it's going to take to get there. And from there, they stopped. They took a breath. They said 8. They counted loud, and they were able to get there without freezing once. So that was a way that I could incorporate that even without having a Parkinson's diagnosis. Okay, another one is in expressing emotions, and I have done this with my cognitive fitness virtually. It's a lot of fun, and it gets them laughing and actually building that camaraderie, like I said. So if you have a mirror in the gym, we did it in our certification lined up, and we all closed our eyes except the first and second person. our instructor gave us an emotion that we had to act out. So maybe it was happy. So the first person would stand and smile, and they would act it out. And then the second person would be looking at them, but they would have to do it even bigger. So maybe they ended up like, then the third person opened their eyes and had to make another one even bigger. And so by the end, you maybe will get someone like, and they try, it's really fun because then they try to guess what that emotion is. So they get them laughing. So giving them not even like those basic emotions, but just some of those kind of, like scared or afraid or frightened. Those are all good ones. And it helps with their masking as well. And lastly, imagery. So having them walk through the room, having them imagine that they are an animal, have them imagine that there's cobwebs in the room that they have to go around. So this one here is walking and acting like a tiger. Okay, walking through the jungle, and they can be intentional about actually walking like the tiger. And then you might have them do that for a minute or two, and then pause and say, okay, now you're seeing an antelope. You have to wait, and then you have to pounce on them once you're safe. And I'll show you in the next here. This individual in the blue came in as probably Honan Yar, if I had to guess, was about a 4. So pretty significant. And he was started and modified in a chair for this task. And by the end, he was acting like a tiger and as a crocodile on the floor. And so that just shows that he felt confident enough in his movements that he was able to get on the floor by himself. Nobody prompted him to. And he felt like he could because he was a part of the group. And then maybe acting like a graceful butterfly, flying through the sky. But then all of a sudden, a gust of wind. And so act like you're a butterfly with a gust of wind and trying to stay on track. Acting like an alligator, like I had mentioned he did. And then pray. You see a prey and you pounce on it. So making it really fun, making it intentional, and it gets them a sense of purpose for movement, but also gives them that idea that they can do things that maybe are hard, but then, just walking around. Okay, so here are a few resources. This is the Partey website through the Parkinson's Exercise and Wellness Center. And then there is a YouTube video if you search Partey or Parkinson's Art of Expression on YouTube. Stephanie Goodman's information is there. And then if you have any questions or want to collaborate, feel free to email me. Thank you.
Next up is Ryan. I told him he was 4th and how he's 2nd, so he's a little caught off guard. Sorry.
Yes, I was checking my phone and I heard my name, so here we go. Okay, we are going to be flying today. I practiced this in front of my 15-month-old, and she got through the first slide, so hopefully I can keep your attention a little bit more than that. We're going to be focused on the complexity of concussion. Quickly, the objective is just going to be looking through the 7 domains that we have at our complex concussion program at On With Life and being able for you guys to recognize some of those signs and symptoms. The big thing we're going to be looking at is some out-of-the-box ideas, some things you might have heard before, but also things that I hope that you're able to put into your practice or to recognize in people who may have had a concussion as well. So really quickly, I'm hoping all of you have a general idea of what a concussion is, but the CDC defines it as a type of traumatic brain injury or TBI caused by a bump, blow, or jolt to the head, or a hit to the body that causes the head or brain to move rapidly back and forth within the skull. The big thing is concussions are extremely complex. There's not one thing that occurs after every concussion. Kind of like we say with any brain injury or such as a stroke, if you've seen one concussion, you really seen one concussion. People come in with a variety of different impairments following concussion. And then there's many factors that play in the role of concussion recovery. At On With Life, we usually see people out of the acute phase. So normally, within concussion, it recovers within a 7 to 10 day period. And that's what we see as normal recovery. Any symptoms that last longer than that, so anything beyond that 10 to 14 days is what we call post-concussion syndrome, or another term for it is persistent post-concussive symptoms. There's no universal definition of this yet, but it's really anything that is prolonged symptoms beyond normal recovery period from a concussion. So what we're going to do is we're going to look at all the domains that we look at On With Life following concussion. The meat and the potatoes is going to be a point of interest in each category that we see, and that's kind of unique in each of these categories that you might have not thought about, or you have, but a point of interest, an out-of-box, an idea that you can take back and put into your practice. I also put some common signs and symptoms, and then at On With Life, oftentimes we have specific disciplines looking at each of these domains. When we have persons served come in, they might have impairments in a couple of these, maybe 1, 2, or 3. They don't often or have to have all of these. So vision, so some quick signs and symptoms, photosensitivity, blurred vision, the list goes on and on. The important thing to recognize with this, or the meat and potatoes of it, is almost 70% of the brain is involved with vision process, which is a lot. So when someone gets a jolt to the head, it's understandable that they're going to have some sort of visual impairment, most likely. The interesting thing is it doesn't always appear immediately. So a couple weeks down the road is when we might see some vision changes. And so we have to remember that just because we don't see it day one, oftentimes, like at On With Life, when we see them down the road, they're probably going to have some vision impairments. A big thing that we've done is get into contact with local neuro-optometrists or optometrists that have experience with post-concussion injuries, so that we have a referral source, but we also have someone to work hand in hand so that we can begin that recovery process as soon as we can. Vestibular impairment. So the vestibular system, if you haven't heard of it, is a little balance system within our inner ear. Any damage to this system can cause vertigo, dizziness. It can really throw off someone's functional ability throughout their day. The thing to remember, let's say someone comes in following a concussion and we find out that one side of the vestibular system, we have one on each side, is impaired. That damage to that system is most likely going to remain. What we're doing as therapists is we're retraining the brain. We're working on brain compensation. So one side of the ear might be sending some information that is different than this side, and that causes those symptoms of dizziness because the brain gets confused. So what we're doing with therapy is we're helping the brain to recognize this as the new normal through working on the motions that are causing people to feel dizzy and retraining the brain to say, it's okay, this is our new normal, and through that, we can get decrease in symptoms. And then oftentimes, PT is the one working on that. Cervical, so neck. So with concussion, almost always you're going to have a whiplash injury because of the energy that it takes to get a whiplash injury is a lot less than it takes to get an actual concussion. So people come in with stiff necks, and if you call their name, they turn like this, right? They stopped using their motion because it might cause pain, neck pain. It might cause fatigue or headache or dizziness or disequilibrium. So this hypothesis says, or this theory says, that when we stop moving our neck, we decrease the stimulation to the receptors within our neck. And these receptors within our neck provide our brain with awareness of where our head and body is within space. And when we stop moving our neck, we decrease that input to the brain, which can cause some disequilibrium and dizziness. So a cool thing, or the big thing to take away from this, people dealing with this impairment, is that we can work on proprioception with head and neck movement. So we have a laser system that we can attach to someone's head. They can do activities, they can start moving their head again and getting a visual cue of where their head and neck is in space, which over time can help decrease their symptoms of dizziness and disequilibrium. Psychosocial impairments. This is a very, very big one as well. Most always, especially post-concussion syndrome, these people have been dealing this for a while, and it's tolling. So we see people who have an increase in anxiety, depression, really struggling with what they're going through. Sleep, sleep, sleep. That's all I can say about this domain. We have to address it immediately. Research is showing that impaired sleep is connected to slower recovery and increased severity of post-concussion symptoms. So immediately we need to figure out, are you getting adequate enough sleep? Are you putting your phone away before you go to sleep? Are you getting those 7 to 8 hours? Because we can even see, if we get sleep on board, we can see an immediate decrease in some of our symptoms, especially related to the psychosocial domain. Cognitive impairments. I think this is a really interesting one. Again, this is a very common one we see after concussion, where someone comes in and they're really struggling with memory, attention, executive function, aspects like that. Another thing we see, especially when people are dealing with this for a long time, is that they are very hypersensitive to any change that they notice following their concussion. So there's research out there, or there's surveys that I was looking into, and they were asking people, how often do you forget your keys? How often do you forget a name? And it can be up to close to 50%, and that's normal. And so what we want to do is kind of focus on the prior level of function. Where was that person's memory prior to their concussion? Because I forget my own name sometimes when I'm talking to people, and so that can be a normal part of life, but when it's exaggerated, yes, that can be involved with concussion. But we don't want to put the person served into a cycle of worrying that everything they're noticing after the concussion is directly related to concussion. We're almost there, we're doing great. Maybe not. There we go, okay. Autonomic nervous system, again, following concussion, we have a metabolic injury or an energy crisis where our body's not making energy as well, but it's the exact thing we need, is where we need that increased energy to bring back cellular balance to our bodies. We used to teach people that they need to sit in a dark room for 2 weeks until their symptoms go away following concussion, and we know that's pretty detrimental to them now, because right when they open the door or they open the window and the light hits them, they go downhill. So the big thing to remember when working on people who have generalized deconditioning after a concussion injury is sub-symptom threshold. So when we're trying to get back to work or we're trying to get back to school, we want to increase their activity, push into those symptoms a little bit, but stay as much as we can below them as we slowly recover. And this will help them be able to tolerate more throughout their day, but not putting their symptoms to 10 and making them regress. And then finally, after concussion, a lot of times we'll have migraine-type headaches or headaches in general. So those would look at photosensitivity, headache, dizziness, and even some anxiety or personality changes. Again, you can see how truly complex concussion is, and that we're looking at so many different aspects, and emotionally it can be so tiring to people, especially if this is years or even or months or years after their initial concussion. So the big three: sleep hygiene, stress management. If we need to worry about cognitive behavioral therapy or refer to a counselor to help decrease management, we know that anxiety, depression, increased stress can all lead to slower recoveries from concussion. So once we get sleep on board and stress managed, hopefully we can see a decrease in our post-concussion symptoms. So last slide, concussions are complex. I hope in each of these categories, especially that we look at on with life, you can take just a little bit of a truth nugget to take back and say, oh, I wasn't thinking about that when I was dealing with someone who was dealing with vision issues or their headache or something like that. So each discipline might look at something different, but we have to be the best that we can be to coordinate and communicate with each other so that we're providing the best quality and highest quality of care for our person served. Perfect. We did it. All right. Thanks, guys.
I'd like to thank Ryan for explaining exactly what we do with people who are long haulers. Thank you, Ryan. So 2 years ago when COVID hit, would I have ever imagined being up here talking about working with people post-COVID at On With Life? No, because it's not what I thought it was going to be. So what we're going to take a look at today is like, what the heck could you possibly expect from COVID? The list will keep going as we'll learn, and then kind of some 1 to 2 things that maybe you hadn't thought of before if you have somebody who is a long hauler. So when COVID first hit a couple years ago, I thought to myself, oh boy, those people, I'm so sorry. I hope you don't get COVID and end up in the hospital. And that was my kind of thinking, was the folks that are get in the hospital with COVID are the ones that are going to need the rehab, and most of those folks are probably going to need, respiratory therapy, pulmonary therapy, those kinds of things. I had no clue that we were going to be working in outpatient therapy at On With Life with people who were post-COVID, unless they had, like this very complex kind of recovery from being in the hospital. Well, then we all learned that, hey, some people who get COVID never go to the hospital, and they have a long recovery. And as we started to learn, the term long hauler, post-COVID started to emerge. And so that's when I started kind of noticing words come up like brain fog. I thought to myself, that's interesting. People have never been in the hospital and they have COVID and they're still having problems. Well, that's different. Fatigue, okay, that makes sense. Yeah, because you got to recover from this disease. Well, then we had, I think it was in May of 2020, we had a person come into our outpatient department who had significant vestibular problems. He never was in the hospital, and his vestibular system was jacked up. And I thought to myself, well, that's really interesting. So then I thought, well, we'll probably work with folks with brain fog, maybe, or, our PTs will work with folks with the vestibular system issues and such. I might work with some people who are having fatigue issues. So that's kind of what I thought maybe we might do in our outpatient department. And then we were, I wasn't told, we were informed that we're considering to develop a post-COVID program for our outpatient department. And I thought to myself, what are we going to do with these folks? Because I've never worked with anybody post-COVID. I don't know what to do. There's literally no research that tells us what we're supposed to be doing. And so I'm like, okay, I'll focus on some fatigue because I'm anticipating that's going to be a problem. And so that's kind of what I was kind of anticipating as we were going along. Well, then folks started coming in. And we soon realized that not only are they having similar symptoms as, fatigue and brain fog and vestibular issues, wow, their vision can also be affected. Wow, that is very fascinating. And then as we started working with folks over the last couple years, the more I started noticing, wow, I can't always remember if I'm working with somebody who has post-COVID or somebody who has post-concussive syndrome. And it's very interesting. And so I would be interested to see if any of you have noticed that too, if you're like, wow, now, Okay, Susie, now did she have a concussion or did she have post-COVID? Because she cannot tolerate a bright room. She can't tolerate the sun anymore. And so some of the things that we've noticed with folks who are long haulers is that they have photosensitivity. They have headaches. They have eye strain. They have oculomotor dysfunction, which are all things that we see with folks who have post-concussive symptoms. Well, what's interesting is also not only can it affect how our brain is processing vision, our eyes can also be affected by COVID, which I've been starting to read some more about this, and not that I'm scared, I don't want this to be doom and gloom, but this is definitely not something that I was anticipating. So COVID can actually affect our cornea and our retina. And so that, if you add that on top of how your brain is processing vision because of the COVID may have got up into your brain and is affecting your brain cells, and you add that on top with eye problems themselves, that is where we might see some differences with vision compared to post-concussion. And so, gosh, well, what do you do? I don't know what to do. I've worked with people with post-concussion. I guess I'll do kind of the vision assessments that we do with folks with post-concussion. So one of the main things that we try to include, obviously, kind of like I was thinking about what Dave was talking about and how when folks come in for their evaluation, I've had a preconceived idea of what they are going to be experiencing. And so sometimes you may not get to the oculomotor screen this first time that you're meeting them because they need to tell you their story. And it's very similar to other folks that I work with post-concussion, that they come in, they need to tell you their story because it's all in their head according to their friends and family. So obviously, when you're getting to know people who are long haulers, take time to listen to their stories and then start to identify if you've noticed them saying anything about vision. And if so, or even if not, within, like your first or second session afterward, I would recommend doing an oculomotor screen just to see how their eye movements are doing. Because some of the things that we've noticed is convergence problems, saccadic problems, and even pursuits. They can have jerky eye movements. They can have eye strain with these oculomotor movements, very, very similar to folks with post-concussion. And then we also do what's called the developmental eye movement test, where they read numbers, and then we can compare them to what would be normal. Some people will be spot on. Other people are really reading quite slowly. So how can we treat folks is we use a lot of what's called the 20-20-20 rule for folks with post-concussion, and we've been incorporating this with folks who have long haul symptoms too, where if you're doing close work reading for 20 minutes, take a break, look at least 20 feet away from what you're doing for 20 seconds so that you can pace your vision needs throughout your work time. The other thing that we teach folks is when they're giving their eyes a break is eye cupping, where you make a little cup with your hands and you place it like over your cheeks and you close your eyes and you breathe for like 5 or 10 breaths. And then we also have been doing oculomotor exercises with folks to help retrain how their eyes are moving, strengthening the eye muscles and such. And then very, very similar to post-concussion symptoms, we were referring folks to neurooptometry. I actually had one of our neurooptometrists write in his recommendations and his findings that when he was working with this person with who had long haul symptoms, that it was very similar to post-concussion. So I thought that was fascinating too, that he was seeing that also. And so here are some of the areas that found some resources to kind of verify kind of what I'm seeing and kind of what to keep looking for. So thank you, Ryan, for describing long haul symptoms to folks too.
I need a little, thank you. Okay, I'm Megan, and I'm one of the speech therapists at our inpatient program. Can you guys hear me okay with this? Perfect. Okay, Gail is right. 10 minutes for me is a hard thing. So my mom used to say when I was a kid I could talk to a wall if it would listen. So I'm going to do my best to stay within 10 minutes, and that's my challenge for today. So I'm focusing a little bit on our stroke rehabilitation, but before I get talking about the item, which is our stroke education book, I want to give you a little bit of the backstory on how we decided to create this education book. So as healthcare continues to change, On With Life and our inpatient program has experienced what many people have, and that's a shorter length of stay on average for the people we serve. And so as a result, as an organization, we kind of made this determination that we were going to focus our rehab philosophy on an overarching rehabilitation goal. Yes, everybody we work with has many, many goals they're working on, right? But they all also have this goal to leave On With Life. And the majority of people we serve are leaving and going home. And so with the shorter length of stays, we felt the need to restructure our conferences, the monthly care conferences we have, and kind of better direct some of the things to make that happen. You know, we felt the time crunch in trying to accomplish everything we needed to and wanted to in the same amount of things in less amount of time, right? So restructuring the conferences was one step, and then also this idea of this rehabilitation goal influenced the design of our stroke rehabilitation book. About that same time, we were getting close to our CARF accreditation and had made the decision that we were going to also go for stroke specialty in CARF, and so that required us to do a little bit more with our stroke outcomes and the tracking that we were doing there. And we needed to define a little bit more these distinct differences between rehabilitation for stroke and rehabilitation compared to some of those other acquired brain injuries. About that same time we were going through that change at On With Life, we got some information from the American Congress of Rehab Medicine conference that was talking about, it was related to the stroke patient's inability to really talk about and recognize those risk factors, which are huge, right, in the interventions that we do to manage those risk factors and reduce secondary stroke. The numbers that were shared at that conference were pretty staggering. So we took note of that as we were working on our definition of our stroke program. When we were further kind of defining our stroke program, we gave it the title Engage. Now that you've heard Dave talk this morning, kind of see where that came from, right? So engagement and effort is really intertwined in what we do at On With Life and how we view things in our philosophy. So using the word engage is what we decided to do to title kind of our stroke program, using engage as an acronym with the hope that the information with our title would remind people what is really needed to maximize outcome and benefit in stroke rehab. And then much like Ryan's domains of care with post-concussive, we organized our stroke program in a very similar way. In the different domains we wanted to make sure we were hitting and everything that we're doing kind of fall within. So you see those domains listed there: psychosocial, medical, nutrition and dysphagia, communication, cognition, that functional status, and then this last piece of education, outreach, and prevention. So, sorry you can't see those bullets under there very well. So as we further defined our program, we decided that we wanted some kind of tool to house much of that information. And in that process, we started to develop this stroke education book. We wanted that education book to target all 7 of those domains, make sure that everyone was represented within the book. we wanted to make sure it was following that newer conceptualization of this rehab philosophy of that overarching rehabilitation goal. So that's part of the education book. We wanted it to be a transdisciplinary tool. So as we created the book, we had all parts of the team actively involved in the content and the creation of it, and also the implementation of it. And then, by nature of the title, it's an education book, right? So we wanted this to be an educational tool, including the things you can't really see, I don't think, very well, but injury-based information for the person served, information on risk factors and management of those risk factors, and secondary stroke. Like we talked about that information that came from ACRM, the inability for stroke patients to recognize those risk factors and understand how they can prevent secondary stroke. We wanted to make sure we were doing everything that we could to educate and provide that information, using the stroke book to help us do that. And then also, kind of one of those major, clear, distinct differences in stroke rehab as compared to other acquired brain injuries is that need to recognize those and manage those risk factors. That's not something that's in the same kind of rehab for something like a TBI. But when you have a stroke, we want to make sure you're aware of your risk factors, aware of how you manage those, and prevent it from happening again. We also included in our book secondary risk factors. So yes, you have all those medical risk factors. You have maybe diabetes or hypertension, things of that nature. But as a result of the stroke, what am I now at risk for? So maybe that's things like sleep difficulties, or maybe now, because of the area of my stroke, I'm at risk for malnutrition or dehydration, or maybe I'm at more risk for falls or more risk for social isolation, those kind of things. So making sure we're educating and communicating those kind of difficulties. And then we just, in the book, wanted some education on the other possible interventions and terminology people come across. What are those common difficulties people with stroke might have, and help people recognize and provide a tool to maybe build some insight into some of those changes. We also wanted it to be more than just a book to read, right? We don't want to just hand people more pamphlets, more information that they've already been given, right? So we wanted it to be interactive. So within the education book, we have worksheets built in and interactive components, and that's how we can really personalize that information to the individual. So where is your stroke? When did it happen? You know, what are your personal risk factors? What applies to you? That kind of information. It also is a house of some different resources about On with Life specifically, but also resources for once they leave our inpatient program and go out into the community and other places. What are some of those resources, and what could that look like? And then there was also a tool, we talked about those outcomes earlier. We needed some more stroke-specific outcomes, and the stroke education book is a way that we were able to measure and find some of those. Maybe? Well, I'm going to keep talking. There we go. Thank you. So as we got that book developed, we put it to use. So I want to kind of talk through what that daily use looks like now. It became pretty clear by the nature of an education book, things like that speech therapy was probably going to be our discipline that kind of took the reins in at least getting it started. So they provide the book to anybody who comes in and provide this initial pre-test. That pre-test looks like just various questionnaire, more of a questionnaire than a pre-test actually, and going through, does your team understand your rehabilitation goal? What risk factors do you have? Just gauging what their knowledge is prior to even starting the education with us. It has that overarching rehabilitation goal that we talked about, and then it has all that education information. And this is where we can start collaborating with other disciplines. It's not uncommon when we go over the person-served specific injury that Dr. Logo and our neuropsychologist may come and join us in a session and go through imaging and talk about the injury specifically. Or when we go through risk factors, that Sean, our PA, might join us in a session and talk specifically about their risk factors and what they're doing to manage that and what that will look like ongoing. It also has goal-based information, but not just those specific, you know, I want to walk 200 feet with Min Assist, but what makes you tick as an individual? What can we do to help you achieve your goals? Maybe that's what we're going to talk about here in a little bit, pet therapy. Or maybe you're like me and you're uber competitive and everything needs to be a competition in your therapy. You know, what's going to help you achieve your goals? We have that kind of information in there. And then all of the information we talked about, the changes they may be experiencing. A lot of times speech therapy will go over those common changes and we work on insight. You know, is that happening with you? What's that look like in your journey? And what are we doing to help you work through that? And then those different resources. So, the outcomes. We've been doing this for a little while now, a couple years. We have some outcomes that we've started to measure. This is the results from the questionnaire We said speech therapy does it at the beginning. We also go through that questionnaire before somebody leaves. So we have the pre and post measure. When we looked at it in 2020, blue is the pre-test, green is the post-test. So in all those questions, understanding my goals, understanding the diagnosis and the risk factors, we saw them all improve from admit to discharge. It looks a little misleading on some of them where the third column looks like the green is less. That's because it's how many answered no. How many, understanding the risk factors, if they weren't able to name any, that's the no. So it's a little bit skewed. But improvement across the board in 2020. Same thing in 2021, even a little bit bigger jumps from pre to post test, seeing improvement across the board in their ability to understand their diagnosis and their risk factors. And then this is just comparing the average number of risk factors they were able to name in 2020 and then 2021. So comparing blue to blue, blue is, in the first chart, is pre-test for 2020, and the second graph there, the blue is the post-test. So you see the blue to blue is a big jump, and 2021 even a bigger jump in their ability to name additional risk factors. So we feel like it's helping. We feel like the people that are leaving us are leaving with good education and good knowledge of their risk factors and hopefully what they can do to prevent that secondary stroke. So next steps, biggest things we want to do is continue to track and compare those outcomes and see if there's anything else we want to be looking at. We continue to make revisions all the time. Recently, I realized we don't probably have enough in there on the role of sleep apnea. We don't have a lot of vestibular information in there. So some of those things we're still tweaking all the time. It'll be an ongoing project to do that. And then we're working on more specific ways to involve that transdisciplinary team. Like I said, speech therapy has taken the major reins at this point and have collaboration through those specific things like goals and understanding their diagnosis, but we want more and more involvement, so still working through that. And I think we're on to Boo and Jeremy.
Thank you. Oh, thank you. Yeah. Hey, so let me. Hello, everyone. My name is Jeremy, and let's bring Boo out here. This is Boo. Boo, can you sit? Thanks. Of course, she's always facing me. That's much training. She's been trained well to focus. Normally, she would carry her bag up here, but I think she's a little nervous. She didn't want to do it for you guys. So we're going to talk about pet therapy. We're going to talk about the effects that has on our role as therapists. I'm a recreational therapist. And we're also going to talk a little bit about the differences between a therapy dog, a service dog, and an emotional support animal. Because we get a lot of questions. Can I pet her? Is the number one question I get from most people. And so we're just going to do a little education on that because we do want you to pet her. So, yeah, you can tell she's worn out already. All right, so this is Boo. She's a local girl. She came to us from Iowa, not too far away from here. She is an English retriever, and she is 3. She'll be going on 4 here in August. So one of the things we're going to talk about is, of course, her role as a therapy dog. And so not only is she man's best friend, but she is also medicine. A lot of this plays into what Dave talked about with the EDSO, and so we're going to dive into that a little bit later in the presentation. But one of the things you need to know about therapy dogs, they are trained. She underwent 18 weeks of training with my wife and I. My wife is also a certified rec therapist at Home of Life as well, and so the two of us were able to take her home and do her training, and then of course she's been working with us ever since. So she has, I was doing some calculations, this is a low figure, but she has about 4,000 hours of service in already in just these couple of years. This is Boo tooting her own horn. So some of the places that she serves are hospitals and hospice settings, short and long-term care, rehabilitation centers, schools, and even disaster areas. So pet therapy is used in both of our programs, long-term and short-term. And so we have therapy dogs here in Ankeny. We have a therapy dog, and then of course here in Glenwood. So some of the physical benefits, of course, are exercise. Just working with animals in general can release a bunch of endorphins. We talked about those earlier, Dave did, which helps the perception of pain and stress. So this individual here in this slide is one that maybe doesn't want to get out and really doesn't feel like doing it, but when Boo's around, all of a sudden he starts feeling differently about that and feeling differently about his therapy and feeling as if maybe he could give it a try. Some of the other things that comes with, of course, the exercise and the neurotransmitters is improved motor skills. And then fighting fatigue. It has been shown that pet therapy is used to fight fatigue pretty well. And as you guys heard earlier, fatigue is a big problem with TBI. The emotional benefits. Okay, so here's the Etso stuff again that Dave talked about earlier. So she is actually an oxytocin machine here. So she not only produces oxytocin when we pet her and ourselves, but she also produces oxytocin in herself. So there's a connection made there for a reason, I believe, that it's beneficial for both parties. I've always wondered, what brings a dog around to be pet? Well, now you know, because they're getting a shot of oxytocin as well. It also increases serotonin, which is a feel-good receptor, and it also decreases cortisol, which is associated with stress. And then there are the social benefits. And this gentleman here, his name is Jeremy, and he is very active. He is very purpose-driven. And so Boo has helped him with some feelings of isolation and loneliness. Oftentimes he's looking for an outlet, and Boo has been a good outlet for that. This picture is when she was pretty young because he helped us quite a bit with the training process. It wasn't only important that she could listen to commands from my wife and I, but it was important that she could listen to commands from other therapists and also those that she's living around. And so he helped in a number of ways, but this is a picture of, he's getting ready to take her out for a walk, and you can see he's got the treat bag, and so he feels pretty empowered with that, and he's able to treat her when he wants to or when she follows commands. He is nonverbal, but he does use some devices to signal when he wants to communicate, and so we've taught Boo how to recognize those signals and also come to that. And so it's been pretty effective. It does also help to improve focus and attention. One of the things we do with Jeremy is we have him load a maze for Boo with food. And so then she has to pull a number of levers and triggers and things to get to that treat. So it causes him to work on his fine motor skills and attention, and it also causes her to work on her fine motor skills and attention. It's pretty awesome. And of course, enhances the feeling of calmness and relaxation. There we go. So all this hard work does make her tired. Boo it can be seen laying around quite a bit, but for good reason, because like I said, we keep her pretty busy. If at the end of the day we just stopped with pet therapy, just stopped with her being a therapy dog, that would be probably the standard. So one of the out-of-the-box ideas that On With Life does is we incorporate Boo in a number of ways. And so I'm just going to kind of discuss some of those other ways that she also serves us, the On With Life community. This is my daughter. They were born about a year apart, so they've kind of been spending a lot of time together, and we did have another dog at home, and she really did like that interaction. And of course, that's my bed and my spot, and that's pretty much where she lays until I get there. So when she's not laying around on the job, we love puns, she's busy wearing many other hats. So Boo is pretty good about putting on wigs and hats and helmets. And so I couldn't help myself here. The wigs, I have about 30 more pictures. We just sat one day going through a Halloween tote trying on wigs, and I think she kind of liked it. I don't know, she really just sat there and allowed it and didn't give me too much of a hard time. So one of the cool things about having a therapy dog is you have a travel companion. So we really value community integration at Home with Life. We really value exploring new opportunities, whether it be leisure or education. And so we believe in getting out quite a bit. That's something that we've been very fortunate to be able to do. And so here's a couple of the folks we serve. And last year, we were blessed with this electric bike. And so Boo's been coming along for rides as we explore that with our person served. And that's been pretty cool. It gets her some exercise, which she does have some doctor's orders for diet and exercise. So it's good for her as well. Pedestrian bridge. She goes just about on any outing that she can. We've even probably pushed the limit on taking her some places, and people really allow it. If they tell us no, she's fine with laying on the bus for a little bit, as long as the weather's fine. So this goes back into some of the conversations that you guys heard earlier, that you need, we use motivator and engager here for this slide, but they need to be invested in the therapy, and sometimes they just are not sold on the idea of it. The physical portion of it, they know that would be good for their outcome, but yet they still have a barrier, have a boundary. And so here Boo is actually helping a couple of our gentlemen push a little bit further. They're giving them some saliency in their therapy, a reason bigger than themselves to go ahead and do this task that they're being asked to do. And so this gentleman in the middle, Jeff here, is a great example. He really loves Boo. It's a big point of his day to get to see her and interact with her. And so we're able to get almost twice as much of his standing time out of him if we involve Boo. He will push harder. It just gives him a little more motivation. This is Paul in the basement standing with a couple of our other therapists. And so we have a shooter for those who can't throw, which Paul can, but we're working on standing more on this. And so that will shoot the tennis ball, and so that's pretty good fun. And it bounces all over the basement and gives her something to do as well. And she is our mascot. She aids in just getting out the message of On With Life. She's a conversation piece. We bring her everywhere, whether we're at work or not. And so we're constantly explaining how she serves On With Life, what she does there. And so she's become really an ambassador. And as you can see, she's a pretty good sport. She even has donned some Husker gear, even though I have it on good authority, she's a Hawkeye fan. I said she's just really good for photos, and she's just really makes it a little more fun when we have to when we're invited to do some of our team photos and celebrate some of the holidays. And she is there to lend a hand when needed. So like a service animal, she does have some talents that she can use. She can carry things along with us. She carries her bag, she carries bottles, she carries iPads around the building because we do a lot of video chats through COVID, and so she would carry the iPads into people's room. They thought that was pretty cute. So she does have some benefits there. This is her at her birthday party here on the left. So every year we buy her presents, we wrap them in paper. One year we did bacon grease, one year we did bacon or peanut butter. And then one of the things we taught her to do was to go find things based on the scent. And we play a lot of hide and seek with our person served. They like that. And so we hid about 12 presents for her. She's spoiled. All of our owl's nest is our outdoor sensory garden. And so we hid these things around there, and then we, of course, made a day of her finding them and unwrapping them. And she spent a lot of time licking the wrapper more than getting it off. I think she was more excited about that than anything else. This is her at the house, so she will carry her dog food bowl around when she thinks it's time to eat. She watches the clock. She knows exactly what time it is to eat, and she will come and let you know. And then this is her delivering Christmas presents. So we had 2 years there where we did a lot of our recreational therapy was done in person serves room because of COVID. And so we did a lot of events over the last 2 years, like Christmas, Valentine's Day, and things of that nature, while they were in their room. And so This is a picture of Boo. She was helping Santa that day, delivering presents to people. And so she just adds excitement and fun. And of course, she is a best friend to many people, but to Dan mostly. So funny story about Dan is he had a black German Shepherd named Ginger years ago. And so he affectionately calls her Ginger. And he really knows. We had a conversation one day when it was just him and I. He said, yeah, I know it's really not my Ginger, but he still calls her Ginger, and he lets everyone else know that's his dog Ginger. And so these guys are best buds. Boo goes and sees him daily. She gets in the office running, and she would usually go find a couple of her favorite people, and Dan is one of them. Dan loves her so much. And so I have probably 100 photos of those two together. These are just some of the more recent fun ones. We had cookies made for her birthday. Those are edible dog cookies. And so Dan's not going to eat that. He just wanted to show it off. So our person served helped us make some edible dog treats and things of that as well for her. But it just goes back to that relationship, and sometimes a dog can really bridge a gap. And I think just going back to what Dave was talking about is one of Boo's best things is that she will crawl in the hole with you. And back a few slides, she's in a lot of people's beds. And what you don't know is she has an uncanny wit of knowing where people are. And so she sought out a couple of people who were kind of nearing maybe the end of their life. And so, she spent some time with them in their beds, and when they were down and out, she was there just hanging out with them on her own will. Sometimes I got to lead her up there, and then sometimes I have to go find her, and here she is laying around with someone. She doesn't tell me where she's going most often. So, though Boo wears many masks, there are a couple of things that she is not. That's what we're just she is not a service dog. So again, service dogs, the big difference you need to know is that they serve one person with specific tasks. Boo serves many people, and so in that way, she is different than a service dog, which means you can pet her. So she will be here all day, so please come and get some oxytocin. And the other thing we're going to talk about real quick is support animals. And so the ironic thing here is that an emotional support animal has more rights than Boo does as far as where she's permitted and whether she can house somewhere that normally doesn't allow pets, even though an emotional support animal may have no training at all and may have not proven themselves to be a good fit around many people. And so I just found that interesting for people to just kind of process that and this picture is here because she's in this dollhouse, because Boo is not allowed in housing that doesn't permit dogs, but an emotional support animal is. So that's one of the big differences between those three types of animals. And so just going to leave you with this. This is my daughter walking her at our local park. The volume's a little loud, I apologize. But it just goes to kind of show you that she's really gentle, and I trust her with my 2-year-old walking right behind her. Oh, good, someone muted the volume. My wife is very energetically cheering her on, which is great. All right, so one of the things that we all enjoy at On With Life is a work-life balance. So Boo does get to go home with us at the end of the day. Boo does have a front porch to hang out with. Boo does have some friends in the neighborhood. Boo does have some downtime. So as do we all. I will tell you, when she is done for the day, she does need a little recoup time. But she is always running back into the office once I get her off my bed. She's always running back in and ready to work the next day. And I think it's because she has that balance. And this is just her at our lake fishing with one of her friends, Jeff. Boo does love to go fishing. She mainly likes to catch the bobbers, so we have to watch her on that. She also has jumped into that water a couple of times. She makes a mess. A couple references here. Again, we'll be around all day. She does know a load of tricks. You guys come pet her. I'll show her off. later on out in the middle area. If you have any questions, please let me know. Thank you. Did you have a question? Yes.
Was you able to go into rooms and all that? Because our dogs, therapy dogs, came up. They're no longer able to interact with patients.
Well, so we follow the
repeat the
CDC guidelines. So there was a time there, and it's still really unclear on that because they haven't really talked about it a whole lot, and they haven't really just done much research with dogs. But there was a time there that Boo was encouraged not to. If we were in a quarantine status, for instance, then she had a lot more downtime. When I had COVID or my wife had COVID, she stayed home with us. And I actually do think she did get COVID, to be honest with you, and she had some issues with it, but she seemed to recover. So she does have time down because of COVID that she hasn't been able to interact with people. But lately, she's back at it, and it did put on some weight because she did a lot of laying around. So we're really excited to be back out there in the community and getting her back out as well. Good question. Any other questions? If you don't have a therapy dog or an oxytocin machine, I encourage you guys to get one. Thank you.